defects. January is National Birth Defects Prevention Month. Every 4.5 minutes, an infant is born with a birth defect. That means nearly 120,000 babies are affected by birth defects each year. A birth defect is a problem that happens when a baby is developing inside the mother. It can affect the function and structure of whatever part of the baby's body that is affected. Some examples of birth defects are congenital heart defects, cleft lip, cleft palate, spina bifida, congenital heart disease, or congenital diaphragmatic hernias. To help us discuss more about birth defects today in children and options for treating them, I have maternal fetal medicine surgeon Dr. Rodrigo Ruano here today to discuss it. Dr. Ruano is a world-famous maternal fetal surgeon who's been on the forefront of developing fetal surgery. Please send your questions to us today live under the Mayo Clinic Facebook page. But please remember that each child is unique, and we cannot offer specific medical guidance for your child today. So Dr. Ruano, thank you for joining us here today.
Thank you for the invitation.
It's an honor to have you here. You've really been on the forefront of developing new fetal surgeries and hopefully altering the course of what we can offer to children with birth defects in the future. So thank you for being here to discuss this really important topic, especially in January.
Thank you.
Let's get started. So can you start by telling us which birth defects are really most common that families will see, part of that 1 in 33 infants affected?
Well, birth defects nowadays affect about 1 in every 33 babies in the United States. So and also the birth defects are one of the most important causes of perinatal mortality. So it accounts for about 20% of death.
Okay.
So the most common defects that we have, are like cardiac heart defects. Then we have brain or cerebral defects, spina bifida, for example.
Okay.
We have congenital diaphragmatic hernia, lung lesions. We have bowel defects like gastroschisis and omphalocele, and we have also cleft lips and cleft palates, as you said before. So
okay, and then there's also kidney areas,
yes.
And that seems to be one area that you've really been on the forefront of developing treatment options.
Yeah, there's some problems that they are not thanks God, they are not so common, but they are very severe because the mortality is very high, and also complications to the kidneys are very, very high too.
Okay. So is there anything that we can do to prevent some birth defects?
Yes. So first of all, of course, having a healthy life, avoiding some medications while you're pregnant is very important. And also, I think sometimes we can use vitamins to prevent some anomalies or birth defects. Like we can use, for example, folic acid to prevent the spina bifida defects. So I really recommend that before we start, the patients or the women decide to get pregnant, it's better to have a consult with the specialist before to plan better the pregnancy. So we can check out those medications, medicines, and also health style to see if we can prevent some birth defects.
Absolutely. So meeting with your primary doctor to just talk about family planning and what you can do to prepare. So taking a prenatal vitamin with folic acid in it. I'm just going to summarize some stuff. Being healthy, getting exercise. If you do have chronic medical conditions, making sure that they're under good control and good management, and making sure any specific medications that you're on wouldn't be harmful to the baby. So we call those teratogens.
Yes.
So those are medications that can affect the baby and cause congenital defects. So that's great. Thank you for sharing those things that people can do to prevent birth defects. Do you have any advice specifically for families that are thinking about getting pregnant? Other than that, anything else to add?
Well, as I said, I think my recommendation is to start having a consultation before with a specialist that can discuss about prevention, not only for congenital anomalies, but birth defects, but also for pregnancy and to check everything. So I think it's very important. For example, even for the folic acid, we recommend the folic acid before the patient get pregnant, and also during the first weeks of pregnancy.
Because that's when it's most important.
Yes.
And there's one other thing I would just mention is about potential exposures that you may not think about. Zika has really
virus,
been in the news. Could you talk a little bit about that?
Yes, that's a very important topic because it's there now. Infection, congenital infection disease is very important because can cause some birth defects too. One is a Zika virus, for example. So if you are planning to get pregnant, it's better to avoid some regions that have the Zika virus, for example, South, for example.
Right. Especially if you don't currently live there. If you do live there, there's the CDC has recommended certain things like taking precautions.
Yes.
And what would those look like? Some of those
Well,
things?
it's better not to get pregnant if you travel there.
Okay.
So and then also that involves the husband, the father, because now it looks like that the husband can also transmit the disease to the pregnant woman.
Okay.
And then we can have the Zika virus, we can have the congenital anomalies. And the congenital anomalies seem to be very severe because they can affect the brain, and we can have lesions, very severe lesions.
Right, and we're still trying to study what exactly, how it affects it, when it's most important for transmission and affecting the developing brain specifically.
Yes.
And then the other thing would be making sure that women who do live in areas where this virus is endemic to try to avoid times where the mosquitoes are out, and that's mostly during the day.
To protect themselves.
And also to be wearing some type of anti-mosquito repellent and reapplying it frequently.
Yes.
Yeah, absolutely. Well, let's move on to talking a little bit more about your specific expertise, which is fetal surgery. So traditionally, birth defects that require some type of surgical repair are going to be done after birth. But over the last decade or so, we've really had advances in what we call prenatal surgery. How does that differ from the postnatal surgery or the surgery that would have been done after birth?
Well, first of all, we offer a fetal intervention, or fetal surgery, or prenatal surgeries for those fetuses or those babies with more complex or severe problems. So that means that there is an increased risk of course, of mortality, and that's the main reason that we offer the fetal intervention. Okay. But the most important difference is that we have the mother, which is healthy, involved. So in reality, we do a maternal fetal surgery. So we do in order to perform a surgery on the fetus, we need to have to perform a surgery on the mother too. So we have two patients at the same time. So we need to have a complex, big team to offer those procedures.
Okay. What types of congenital defects are fetal surgeries available for?
Yeah. So nowadays we have many different options. The first option that we have, the first therapeutic option that we have is for the twin transfusion syndrome, which is a condition that we have identical twins with one placenta with two sacs. And these conditions, whenever we have one placenta, we have connections, vascular connections between them. And then sometimes in about 20% of the time, then we have unbalanced blood flow coming from one side to the other side, and then we can lose the entire pregnancy in about 80% of the time without surgery. So nowadays what we can do, we can put a tiny scope inside the uterus, so through the maternal wall. We can do this under local anesthesia, so it's not a very complex procedure anymore. But we can find the connections, and then we can laser those connections. We can stop that problem. So then we call fetoscopic laser ablation of the placenta anastomosis, a complex name. But then we can improve the outcome. So from 20% chance of having this pregnancy, we can have in about 80%. So it increases a lot the chance of that. So this is the first one, and this has been proved to be the best option for this type of disease, which is not a real anomaly, but is a placental problem. So, and then we have the second surgery that we can offer is repair, in utero repair of spina bifida. The spina bifida is a defect that the spina does not close well, and then we can have brain lesions, and we can have problems. The baby can have difficulty to walk, to have bowel movements, and to control the bowel movements, and to control the urination too. So now nowadays we can close the defect before the baby is born. And then it was proved that it can improve the condition of the brain
Wow.
for these babies.
Okay. Fantastic.
This is the second one. The third one that we can offer, we can resect tumors, like lung tumors or other type of tumors that sometimes can cause cardiac failure, and the baby or the fetus can die. So in order to avoid death or to improve the chance of survival, we can offer this treatment before it's born.
Okay.
We have also, which is one of my main focus, is congenital diaphragmatic hernia,
Okay.
which is a defect in the diaphragm, which is a muscle between the chest and the belly. So we have a hole there, and then the abdominal organs, like stomach, bowels, and spleen, and sometimes the liver, they come up, and then compress the lungs, and the lungs, they don't develop well. So the situation that we call pulmonary hypoplasia, the lungs are very small, and these babies, they have difficulties once we clamp the cord, and they can die postnatally. So one of the treatment that we can offer is to place a balloon inside the trachea. So we call fetal tracheal occlusion. We puncture the maternal belly again under ultrasound. We use local anesthesia, and then we advance the tiny scope inside the baby's mouth, and then the baby's trachea, which is the airway pipeline, and then we occlude that trachea, and then this causes the lungs. That the occlusion promotes lung growth, and then we have a better chance of having this baby alive after birth. So the other surgeries, so I have many surgeries I can talk about, but the other surgery that I perform a lot is that there's another condition that we have a bladder outlet obstruction. So we have a lower urinary tract obstruction. That means that the fetus or the baby cannot urinate anymore, and then the amount of amniotic fluid decrease, and then will cause problems to the lungs, and the lungs will not grow, and we have the same problem. The baby can die just after birth.
Right.
And then also this can cause also problems with the kidneys, because the urine comes back, and then can cause renal failure. So this baby will need dialysis. Those babies that will survive will need dialysis, transplant. So one of the treatments is try to put a shunt. We put a shunt from the bladder to the amniotic cavity, to the fluid around the baby. Or nowadays I develop a technique that we can put a scope inside the bladder, and we can open the membrane, the posterior urethral valves, and we can release the obstruction, and we can help the fluid and the lungs development. We can also avoid renal failure.
Wow, fantastic! Those are really fascinating and very interesting surgeries. How does a family know when they should consider meeting with a fetal surgeon or not, once their child has been diagnosed with a birth defect?
That's a very good question. So I think whenever we diagnose a congenital birth defect on ultrasound, the patients need to be referred to a center where we can have maternal-fetal medicine doctors to confirm the diagnosis, and then based on the diagnosis we can see the fetal surgeon to see if there is an opportunity to treat. So whenever we see a congenital birth defect, we need to have the patient seen maternal-fetal medicine doctor, and this doctor will be responsible to start the entire process.
Okay. Is the timing important about when they would meet with the maternal-fetal specialist and the fetal surgeon, and specifically when they would get the surgery? Is the timing critical?
Yes. So the time is very important, because as soon as we diagnose and as sooner we treat, we will have better results. For example, imagine for congenital diaphragmatic hernia, I need the lungs to grow, and I did some studies on that, and I proved that my team proved that if we place the tracheal occlusion earlier, we were able to get better lungs or bigger lungs, so we improved more the survival rate if we do that. The same for renal disease, for example, if the kidneys are obstructed. So if we can release the pressure, we can save the kidneys. The chance of saving the kidneys are higher.
Okay. So most women, at least in the United States, are getting their anatomy scan, their large ultrasound scan, or between about 18 and 20 weeks.
Yes.
And so the timing after that, being referred after that diet, that something is found in the anatomy to be a congenital defect, is probably going to happen very quickly for these families. Is that correct?
Yes.
Okay.
So as soon as we find the diagnosis, it's better to refer to the center.
Okay. How do you decide? I know that each one of these birth defects are very, very different, but how do you decide whether the child would benefit on going ahead with a fetal surgery as opposed to waiting until after the child is born to try and repair whatever defect is there?
The objectives of the fetal surgeries are first to avoid demise, death.
Okay.
So answer your question, whenever we have a chance of fetal demise or postnatal death, then of course we offer the fetal intervention. And the second is to improve the quality of life. So whenever we have a situation that we can change the natural history of the birth defect, like we can improve the condition after birth, so we can offer the fetal interventions.
Okay.
And this is a general rule for all of the surgeries.
Okay. So really, the severity of the defect is really going to push people to do a fetal surgery.
Yes.
If it's a mild defect and the child is thriving and doing well, and the mother,
surgery.
there's no need for intervention.
Yeah.
Absolutely. Okay. We've had a couple questions. I'm going to take a little break on this and answer a lot of questions about nutrition and pregnancy. The first question was about when did the recommendations for prenatal vitamin and folic acid become widespread, and I think that has been for a long time. We've known that folic acid is related to specifically neural tube defects.
Yes.
And so probably 20 years or more, I would guess. I'm not sure exactly
I think so.
what year.
I think 20 years ago.
Okay, sounds good. So that to answer that question. The other question was about if there is a spina bifida or a neural tube defect, if starting to give folic acid after that's found, can it reverse the defect?
Yeah, so that's a very good question because this is very important. So whenever we diagnose spina bifida in a fetus, we cannot reverse that problem. We can close that and we can avoid more complications. So that's the reason that we offer fetal intervention, because if we close sooner, we can have better outcomes for the brain. Yeah. But we cannot reverse using the vitamins or folic acid. But on the other hand, once she finishes the pregnancy, for the next pregnancy is very, very important to start folic acid even before pregnancy, because we know that patients or pregnant women who had fetuses with spina bifida, they have unfortunately increased risk to have spina bifida again. Okay. And if we do folic acid before and during early pregnancy, we can decrease the chance of that close to the normal population. I don't know if it's clear that, but it's very important.
Absolutely. I think that's a really important point. For especially for neural tube defects that are related to folic acid levels, the most important thing is prevention. And I think that's what the CDC is really trying to promote this month is if you are thinking of becoming pregnant or just a remote chance, taking a folic acid supplement in the form of a prenatal vitamin is not going to be harmful
and
to you.
Vegetables too.
And green leafy vegetables are very high in folic acid. So eating those or taking a supplement is going to be very low risk to you, but high benefit to a potential baby that you may conceive in the future. So this question, next one, is kind of leads to more about kind of long-term treatment. So you mentioned spina bifida. So children with conditions like spina bifida may have complex care going on for the rest of their life. What type of follow-up should families expect after their child has maybe had one of these fetal surgeries?
So that's a very important question because every time we diagnose a birth defect, we just start the process.
Exactly.
So we need to keep following these patients after birth. Especially if we do a fetal intervention, because a fetal intervention usually is not to fix the problem, it's to get the baby in a better condition to do the surgery after birth.
Okay.
So one good example, as you mentioned, is about spina bifida, and then there is a spina bifida clinic that can follow this baby throughout the entire life. Why? Because we need a multidisciplinary team evaluation and follow-up.
Right.
So this is very important, and this is good for us because we can follow the baby, the patient before they are born, during their childhood, and also after adult. So we need to follow the patient during the entire life.
Absolutely. So in patients that are diagnosed with spina bifida, it's really important for these families to find a good spina bifida clinic that their child could be followed in throughout childhood, and then a transition team through their adulthood years as well. Okay, fantastic. Let's talk a little bit more about what type of birth defects would you not be able to do a prenatal or fetal surgery on? Are there any specific ones that come to mind?
Well, usually we don't offer fetal intervention for many of the birth defects because, as you mentioned, the birth defects can be mild or can be fixed or can be treated postnatally.
Right.
So we usually offer for those that are more severe and are risk of death or complications after birth. So usually we don't offer for those. There are some more severe forms, for example, even congenital cardiac disease, cardiac anomalies that we don't offer. Okay. Maybe in the future we will be able to offer, but nowadays we cannot offer. So.
There's just very few congenital heart surgeries that they're starting to experiment with, right?
Yes.
Okay. How about, as a surgeon, how do you prepare for something when this is still considered experimental? How do you practice and get yourself ready for these kind of surgeries?
Yeah, so that's very, very important. So, of course, we have some guidelines to know the ethical, based on ethics too, and to offer not experimental procedures. Of course, we need to have like a academic environment, multidisciplinary team. We need to have conditions for that. Okay. We need to have approval from the institution, and also we need to tell the patients that this procedure is experimental. Okay. One of examples is the tracheal occlusion that I mentioned is an experimental procedure. It's in the United States. Okay.
So you talk to a team. You're getting IRB approval to make sure that this is ethical to be considered in that patient and stuff. Is there any type of modeling that you use to kind of practice on, or any kind of animal models that you use to help prepare?
Yes. Usually before we do a clinical trial, that means a clinical research, we need to do animal research. Okay. And also we have models to practice and to train. For example, we are going to start sooner fetoscopic repair of spina bifida, that I don't need to open the uterus anymore. Wow. But I have done before, but I need to practice with my team here. So we need to do simulations, and we use models for that.
Okay. Have you guys started using any of the 3D printing?
We use 3D printer.
Okay, absolutely. That is so fascinating how it's really been able to change surgeries in preparation for them.
And we are developing an uterus that mimics very well the real uterus, so we can distend and we can control the distension of the uterus too.
And this is all done in a simulated sort of setting beforehand. Yeah. That's fantastic. Let's talk about some of the advantages and disadvantages that parents might need to consider when they're trying to weigh whether they're going to go forward with a prenatal intervention.
Yeah, again, this is a very important discussion, because we offer the fetal intervention as an option to the patient. So we always give them the advantage and disadvantage, so we can give them the risks and potential benefits for that. Of course, the potential benefits are based on improving the survival rate for the baby, but on the other hand, we need to think that we have risks for the mother and for the pregnancy too. So we know that fetal interventions increase the risks of prematurity, preterm labor, preterm deliveries, and premature rupture of the membranes too. So we know that. Okay.
I have one other question here that I wanted to get to. This person is asking if there are common chemicals that can be harmful that are in the environment that may be passed through the blood-brain barrier in utero. Can you think of anything specifically that may be harmful?
Well, there are, like we
Yeah.
said, medications that can pass the placental barrier.
Right.
It's not only the brain barrier, but the placental barrier. So we can cause, for example, cardiac defects if we take some medications,
Okay.
or some chemicals that can pass the placentas. Yes.
Thanks. All right, so let's move on to another question, kind of back to fetal surgery. You mentioned that this is going to involve a very large team. Can you mention some of the people that are involved in that team to help prepare for the surgeries and treat both patients, both the fetus and the mother?
Yeah, so this is a very huge team involved. So we have different types of doctors. For example, we have maternal fetal medicine doctors, we have neonatologists, we have pediatric surgeons involved, we have pediatric neurosurgeons, we have cardiologists, pediatric cardiologists, we have pediatric urologists, pediatric nephrologists. So we have all types of different specialties that could help, that can help the baby. And also we have all the nurses, the coordinators, we have social workers. So it's a big team.
It is absolutely a very big team, but without all the different team members, it probably wouldn't be as successful.
No.
Absolutely. Well, let's finish up today with one last kind of question, maybe a little bit more of advice. So for a family who's been recently diagnosed with a severe congenital defect or fetal defect, what advice would you give to that family as they start to take in this information and go forward in the process?
Well, we know that this information can be very difficult. First of all, my recommendation is to try to calm down, because the first impression is, of course, is not the best. We know that, and then sometimes it's not as is the worst. So we can. My recommendation is that to calm down and to get referred to a center that we can confirm the diagnosis first, that we can discuss about the diagnosis. The patient can see different physicians and specialties that can provide different recommendations related to their specific areas. And then if there is any condition to treat, we can treat. If there is no need for treatment prenatally, is even better because we can treat postnatally.
Absolutely.
And I always try to give hope to the patients because first of all, this is my job, but I'm fighting for those babies too.
Absolutely. I would also add, it's important for families to know what they're dealing with, and so to educate themselves and to read up on the condition as much as they can, so they come into it with some knowledge and be able to have good discussions going forward with their medical teams.
And this is exactly our main objective, to inform the patient as much as we can. We provide the information that we can to the patient, so the patient can live here with all the information necessary for them to understand the problem and to know what's going to happen in the future too.
Absolutely. Well, this has been really, really interesting today. Thank you so much for joining me and sharing your depth of experience and knowledge about fetal surgery. It's been really enlightening. Thank you so much.
Thank you for the invitation. Thank you for this opportunity.
Absolutely. I'm just going to finish up today by saying thanks for joining us. Join me in 2 weeks on January 19th with Dr. Todd Milibrandt, who is a pediatric orthopedic surgeon who specializes in sports medicine and scoliosis repairs. So any kind of sports medicine related questions that you have, please send them to us and we'll be happy to answer them, and we'll see you in 2 weeks. Thanks everybody and have a great day.